Welcome everybody. Thanks so much for coming along to our webinar for April 2023. See a few people still coming in there, but that's fine. We are hosting our webinar today from the beautiful unceded lands of the Turrbal and Yagara peoples of Meanjin in Brisbane. And we just like to start off with an acknowledgement of country. So thanks, Karen.
QUT acknowledges the First Nations owners of the lands on where we gather today and pay our respects to the elders, laws, customs and creation spirits of this country. For thousands of years, the First Nations owners have gathered to share their knowledge and stories. We pay our respects to all Aboriginal and Torres Strait Islander peoples and acknowledge the important role they play within our communities. We recognise their long and continuing connection to country, the lands, winds and waters throughout Australia. We recognise that these lands have always been places of teaching, researching and learning.
Thanks for that, Karen. Also just wanted to give you an opportunity to acknowledge the country that you're coming from today. And if you'd like to, just put that in the chat. Let us know the traditional custodians of the land that you're on or the name of the land that you're on. That would be wonderful. While you're doing that, I'll just introduce you to our team. We are from the Palliative Care Education and Training Collaborative, which is a nationally funded palliative care project. And that is comprised of the projects PCC4U, PEPA and IPEPA. And I'm one of the Learning and Development Coordinators for the collaborative, and Karen Wynne, my good friend, who's on the busy seat, is also Learning and Development. And we also joined today by Kylie Ash, who is the National Project Manager for PCC4U. And of course, we'd like to just acknowledge our project lead, Distinguished Professor Patsy Yates. And before we get started today in our webinar, just wanted to take a moment to acknowledge the pain and sadness that is felt through the paramedic community at the moment after the events in Sydney last week. As fellow health professionals, we just wanted to let you know that you're in our thoughts and that we really, truly do appreciate the service that you provide to our communities. In terms of the session today, I'm just going to provide a quick outline of the kinds of resources that we have in PCC4U for paramedic education. And then we'll welcome Madeleine to come and share her work with us. And then we'd like to have a bit of an open conversation about palliative care education for paramedicine and invite you to be part of that. Okay, so without any further ado, let's get into our PCC4U resources. So for anyone who might be new to PCC4U, our project provides a suite of learning resources at the university level to support medical, nursing and allied health students to learn about palliative care. We do have other resources for the vet sector level as well, but today we're just focusing on our university level resources. We have 4 core modules and 4 focus topic modules. And Karen's just going to put the link in the chat now for where you can find our modules on our website. We've written these resources as generic or non-discipline specific, but we have noted feedback from educators over the years that some discipline specific content would be really helpful. And we've started with paramedicine. So lucky you. Some of you might remember attending our webinar last year in August, where we were able to highlight the new paramedic learning guide for PEPA, which has really been put together from a very enthusiastic and engaged group of paramedic educators, really supported that process for us. And we're really pleased that the uptake of this resource has been quite broad and within a few different contexts. So we looked at the content of that learner guide in terms of the undergraduate or entry to practice student group, and had some differing opinions about how best to present that. So some people were suggesting that we should include it as a standalone module, and some people would prefer it to be, I guess, sprinkled throughout our current resources. So in effect, we've actually done both of those things. And I'm just going to share a document with you that you can download today, which is a bit of a summary for educators of where we have placed those resources and links for how to find that. If you are watching this on the recording, or if you haven't been able to download that document today, you'll be able to find it where we have all our other resources on the webinar Educator Community Hub. So I'll share my screen with you now just to give you a little bit of an overview of the website. So give me a thumbs up, someone, if you can see that. Great. Always like to check, because you never want to be showing your emails or Teams messages. So this is our landing page that was shared in the link earlier. And you can see the links there to the 4 core modules and the 4 focus topic modules. So we'll let you explore that at your leisure. And if you continue scrolling down, you can see the start of our discipline-specific content. So we've got paramedic content essentially drawn out of the Pepper Learning Guide and put into our open access website. So we've put the whole learning module in there, and you can click on that. Hopefully that's opened a new screen with the RISE module. Great. And those of you who are familiar with our Pepper Learning Guide, you'll see that this has just been changed to PCCPU colours, added a little bit more context for the undergraduate cohort, but essentially it's the same content. So the complete set of resources for paramedics is here in this module. Having it freely accessible through our website does limit it in terms of using for students, in that you can't track their progress through the module, and it doesn't come back to where they left off when they go in and out of it. So this is probably here more for educators to use. You can use it as a teaching resource. You can encourage students to have a look at it and then maybe submit something based on their work through the module. So that's there available for as a whole, a complete resource. The other parts that we have, did we share that document in the chat, Karen? Great. So if you want to download that, you've got all the links and the information in there. And that document is here as well in the list of paramedic content. We have used some of our PCCPU case study stories, patient stories, in the paramedic module. And those of you who are familiar with our stories, we've taken a little bit of creative liberties and imagine what would happen in the story if there was a paramedic kind of involvement and input. So there's a summary of the case studies here and how we've extended them for the paramedic context. And then as we go through I'll just show you a couple of examples of where we have embedded this content. So I'm going to go into the communication module and activity 4. I hope that's right. Yes, so we're talking about communication principles, and we do have a couple of frameworks in our main resources, but there's acknowledgement that these frameworks may not be as appropriate in the pre-hospital context, in the emergency context. So as we scroll down, we've just got our little ambulance icon, and that has the information about how the adaptation to the SPIKES communication framework. And that was largely based on the work done in the UK, out of the UK, with the Serious Illness Conversation Guide and the adaptation of the ABCDE framework in the pre-hospital setting that was done in the US. So that's kind of how we based that. But we also got a lot of really rich information from our peer review group, and they were able to provide a lot of the key statements and examples of ways to communicate different things. So that resource is there as a PDF downloadable document for your students to use as a reference, and maybe to even talk through in terms of how you would use that framework. And another example, just quickly, is in our core module 3. And in symptom management, hopefully this is all clicking through. Someone will tell me if it's not. So looking down again, you've got the little ambulance icon, and then we've got a section on medications and palliative care emergencies. So the emergencies content is based on the therapeutic guidelines for palliative care, again with input from our expert group on how those kinds of situations might be managed for a paramedic, from the paramedic perspective. So just a couple of examples of how we've embedded that content in our generic or non-specific resources. There's more throughout, but I don't want to take up too much time showing you those today. There's a full summary in that document that we've shared in the chat. Okay, so I would like to now just introduce Madeleine to everyone who may not already know her. Madeleine Juhrmann is PhD candidate at USyd, and fingers crossed, finishing soon. And we had her at our webinar on this topic last year and really appreciated her energy and enthusiasm for the topic and her presentation. And we're really excited to hear her present again today. She's titled her presentation today, Challenging Perceptions, Building Paramedic Capacity and Embracing Integrated Models of Care. Thanks very much, Madeleine.
Thank you for the introduction. I'm just sharing my screen. Is that okay? Can you see? Fantastic. So it's lovely to meet you all. Some of you I may not have met before. My name is Madeleine Juhrmann. I'm a PhD candidate at the University of Sydney, where I'm exploring the role of paramedics delivering palliative and end-of-life care in community-based settings. And I started my career studying paramedicine at Flinders University. And it was during those experiences as a student paramedic that I first came across palliative and end-of-life care patients and felt a great limitation in my ability to be able to provide palliative and end-of-life care. And also those around me, my teammates and my supervisors and my mentors, we all commented on our restricted scope of practice and how we wish we could care better for patients in the community and facilitate those goals of care to live and die in place. So that's what ultimately inspired me to come to Sydney and do my Masters in Public Health, and then more recently my PhD under the wonderful supervision of Professor Josephine Clayton and Professor Phyllis Buteau, who I'd just like to acknowledge now. So a bit of a summary about my PhD. It consists of 4 studies, which I began in the depths of COVID in March 2020. I undertook a systematic integrative review. That was followed by a clinical practice guideline policy review, then a qualitative study, which we undertook last year. And this year we're finalising our Delphi study. Underpinning all of my research is I established a palliative paramedicine advisory group, which I'll talk about in the next slide. Now, the expected contribution of my research, at the beginning, we thought we were going to create a clinical practice guideline. And I think that's a real reflection of my training as a paramedic, that we are, or at least in my training, we're very protocol-based, protocol-driven. And I think that there is an emergence of a broadening scope of practice for paramedics to be more focused on clinical decision-making. And that has evolved over the course of my PhD, in that we are now focusing on developing a framework which is multifaceted from both a structural, clinical service, and then individual level, which I'll talk about in subsequent slides. But the overall goal of this PhD is to develop a palliative paramedicine framework which is suitable for national implementation, to standardise practice across all of our jurisdictions and hopefully influence that around our oceanic neighbours and then further afield as well. In doing so, we hope to achieve 5 key factors as listed on this slide. The first is to enhance out-of-hours care. Second, to reduce avoidable hospital admissions. Third, to facilitate more home-based deaths. Fourth, improve end-of-life care for people with life-limiting illnesses. And fifth, to build an Australian and New Zealand community of practice around palliative paramedicine. So that palliative paramedicine advisory group that I spoke of, I see that some of our members are online today, so hello to you all. We developed this at the very beginning of my PhD because I had a strong focus on wanting to ensure that whatever research we generated didn't just sit on a lovely shelf at Sydney University, and instead it was translated to practice in real time. I also really appreciate the practical expertise and knowledge of those on the ground, as I'm not on ground and working for an ambulance service anymore. This is really important to ensure that our practice and our policies and research are being informed by those people. So we have representation across all jurisdictions of Australia as well as New Zealand. And then we have some other experts involved as well, as listed on this slide. And they have been wonderful in contributing their perspectives from their respective jurisdictions, as well as co-authoring and some of our research. And I really think it's so important to ensure that within research, it's co-designed by not only researchers and the people in universities, but also the clinicians on the ground and consumers as well. So thank you to my advisory group. I am really indebted to your insight and knowledge. So as I said, the first study that we conducted was a systematic integrative review. Now, this was published in Palliative Medicine Journal in 2021. And we conducted this study because at the time there was a real lack or gap of knowledge in this area. It was very much an emerging sense of paramedic practice. And what we established were the roles, the scope, the barriers and the enablers of practice, both within Australia and abroad. And I'm pleased to say that we only had 23 articles included in this study. If I were to conduct that now, there would be well over 50. So well done to all of you out there. Following the first study, we conducted a comparative guideline analysis of the existing clinical practice guidelines within Australia and then also those abroad with comparable health systems to our own. So that was New Zealand, which has a national guideline, as well as the United Kingdom, which follows the JR Calc national guideline, which is then amended depending on the jurisdiction. And we also chose to compare it with one service in Canada that is part of the broader national best practice approach to palliative paramedicine. And what we identified very quickly was that in Australia, we only have 5 of our 8 services that actually have a clinical practice guideline pertaining to palliative and end-of-life care, which I think speaks volumes to the fact that it is still very much in its emergence as a part of the discipline. Now, you can access both of these articles online for further information. I won't bang on about that too much. But our third study, which I really like to talk to in depth today, is the qualitative study. So after we were able to identify from the 2 previous studies that there was absolutely a gap in knowledge and in practice, we wanted to get insights from those that were involved in palliative paramedicine, not just the paramedics themselves, but the palliative care services, so palliative care doctors and nurses, as well as general practice, as well as residential aged care. As we know, that is such a common site of intersecting between paramedics and residential aged care and palliative care patients, as well as, of course, those with lived experience. So we undertook 50 interviews with a range of participants as listed on this slide here, and we covered all jurisdictions of Australia and all disciplines within those jurisdictions. So it really was a comprehensive sample. And the aim of this study was to elicit stakeholder perspectives, experiences, and attitudes on the role of paramedics delivering palliative and end-of-life care in community-based settings. So we had 3 key research questions. The first one was pertaining to what is the role of the paramedics providing that type of care. The second was, what are the barriers and the facilitators or the enablers experienced by all stakeholders when paramedics are delivering this type of care? So what do paramedics find help them and what hinders them? But what also helps and hinders other clinicians and the consumers themselves as well? And then finally, how can we improve practice? What interventions do we need to make sure that we can assist paramedics to be able to provide that type of care, to assist consumers to be able to reach out for that type of care, and to ensure that we've got integrated care across services and disciplines as well. So I'd like to include this quote with you all. I found this quite thought-provoking when I heard it from the residential aged care manager. She said, paramedics are a highly regarded profession and they have the power to communicate convincingly with families. They help us to take a palliative approach, especially after hours. Now, this residential aged care nurse retold a story of being able to convince a family who were insisting on sending their loved one with a terminal diagnosis and with advanced dementia to hospital for an irreversible cause and a non-irreversible cause, and they were able to, with the assistance of the paramedic, be able to convince the family that they could provide good quality palliative and end-of-life care in place, and that resident was able to die at home, which was a brilliant outcome. So the first paper that the first manuscript that we are developing, which has just been submitted to Palliative Medicine Journal, focused on those first two research questions. It spoke about the role and also the enablers and barriers to practice of the participants and their accounts of those experiences. And what we found was an overarching theme, and that was that the participants kind of saw palliative paramedicine in two streams, or as a dichotomy of thought. There were those in the camp that sat strictly in thinking paramedics are lifesavers. Their role needs to be rooted in the responding to those acute emergencies and adhering to that traditional perception of treating to preserve life. And then there was, on the other side, people saying that paramedics, actually their role is evolving in response to the diverse and the changing needs of populations, including an increasing demand for home-based death and therefore community-based palliative care. And so underpinning both of those, frames of mind were four key themes as listed here. The first was creating an identity. So all participants agreed that paramedics have a revered public identity, and that's shaped by a perception to fix a crisis. You call a paramedic when you are in trouble. And the sub-themes of that were this notion that paramedics are a trusted community clinician. They are who you go to when you're in trouble. But in doing so, there are expectations and beliefs imbued in their training and within society's perception of paramedics that they will always be able to save a life. Paramedics are quite good at breaking bad news, that is, of an unexpected death, of a motor vehicle accident, of somebody who has a cardiac arrest and unfortunately is unable to be resuscitated. They find that quite easy. It's imbued in their training and their expectation of their role. But when they have to approach an expected death, particularly that of a palliative or end-of-life care patient, it can be particularly challenging for them and difficult for the community and those around them to reconcile the fact that a paramedic can do no more to save that life. Also, the road to professionalisation. As we know, paramedicine has jumped leaps and bounds in the last 10 to 15 years in regard to what they can do as a discipline, the registration with APRA in Australia. And I understand that this is a very similar notion that is occurring in our neighbours in New Zealand, Aotearoa, and also in the UK and in Canada as well, that this expanding of practice, a professionalisation of a discipline that was previously seen as a vocational training is now influencing the scope and place of practice for paramedics. We're seeing paramedics wanting to work outside of areas beyond just an ambulance, and that was absolutely advanced through the pandemic as well. Also, there were notes of hierarchies of care. We had GP participants talking about the barriers of being able to provide good palliative care when they are hindered by palliative care services, and vice versa, and residential aged care feeling that they're at the bottom of the chain, and all of these interdisciplinary hierarchies that we're so familiar with, of course, that are influencing this perception. The next one I wanted to talk about was fear and threat. Paramedics are often afraid of palliative and end-of-life care, and they feel quite vulnerable when taking this approach to care. They recounted an emotional cost that was associated with providing palliative and end-of-life care, but in most circumstances that it is some of the most rewarding cases that they get to go to. They also spoke about differing levels of palliative care skills and experience. The older paramedics with more experience spoke more confidently about their ability to take this approach to care, and that simply came with exposure. Whereas junior paramedics felt very restricted and scared of moving beyond what they were traditionally thought was their role. There was also a sense of death denial, not only within the paramedicine discipline, but across the board. Community members, consumers who were speaking with lived experience said before their experience of death of a loved one, they absolutely feared death, and they thought that it was something that you should avoid and not talk about. And it only came with lived experience and exposure that they were comfortable in being able to explore those ideas and the existential notion of death and dying in society, which is very well documented. Finally, paramedics expressed an apprehension to administer palliative and end-of-life care drugs, which was also seconded by residential aged care nurses as well, and sometimes GPs who hadn't necessarily had that training. And that was related to this medico-legal fear of doing the wrong thing and then later being reprimanded for that. So the next theme I'd like to talk to is permission to care. So paramedics, they require consent to move beyond the traditional scope of practice in order to be able to provide high quality palliative and end-of-life care. First thing that came up in almost every single interview was a time on scene expectation. I know that when I was being trained that we were told 20 minutes and go. Now, that wasn't necessarily what we legally had to do, but it was absolutely a part of the service expectation. And there are still jurisdictions whereby KPIs are encouraged to be leaving the site at 20 minutes. Now, everyone here knows and appreciates that it takes longer than 20 minutes to provide adequate palliative and end-of-life care, particularly in those regional, rural and remote areas where you may not necessarily have clinical backup. But in saying that, there was that existential question being posed of what is the role of an ambulance service then? Is it to provide this extended on-time scene care, or is it still to be those emergency responders? And that is a huge question that we have to grapple with, something that I don't pretend to know the answer to. Also, accessing documentation and eliciting information. We all have heard time and time again that if paramedics don't have that documentation right there in front of them, it's really difficult to make those quick calls on whether they should be resuscitating a patient or not, or simply transferring them to hospital or not. And having it at a point of access is something that really facilitated good quality care and the confidence and permission for the paramedics to take that approach. Responding to a change in plan was another aspect of anecdote coming through. This was really interesting to hear, particularly from those with lived experience, about the notion that it's okay to change the plan, that sometimes families will aim to have a home-based death, but it cannot simply be facilitated, and that's due to a multitude of reasons, most particularly carer burnout. Also, the restricted practice and medico-legal responsibilities. Many paramedics from different ambulance services spoke about their limited scope of practice, particularly those in jurisdictions who do not have an existing clinical practice guideline. Treat and referral pathways were spoken of many times. The need to be able to call and get advice, to be able to initiate a subcut medication with assistance over the phone, was significantly improving paramedics' chances of being able to provide good care in the home. Finally, the harsh reality, paramedics offer an adjunct support for community-based palliative care, but they do fill a gap, particularly after hours and in those regional, rural and remote areas. There's also limited access to specialist support, not only for paramedics, but for residential aged care and general practitioners working in those areas after hours. Also, we spoke about that, I heard about the working in silos, that ambulance services for a long time have worked independently, and it's something that they wear as a pride of honour in that they are autonomous and brilliant at their job of being able to work quickly with limited resources. But in order to provide high quality care, they need to have the ability to work alongside other services, not in distinct silos. Another quote from a participant: if someone is having a terminal event, you need some specific type drugs to give very quickly to relieve that distress. I just remember thinking, thank God someone's here to back me up. It was a combined effort to manage his distress, and there was no pressure from those ambulance to take him anywhere. So this was a family member who actually was previously a palliative care nurse. So she had a wealth of experience, but she was supporting her dad to die at home. And she spoke about the brilliance of the paramedics being able to come and assist her with that medication, but not pressure her into taking her dad to hospital. The second paper that we're currently drafting is looking at those opportunities or those interventions, research question 3. So how can we improve practice? And I'll touch on this briefly. We decided to split it into 3 different sections to take a public health approach to this, because as I recognized at the start of my discussion here, practice isn't going to change with a clinical practice guideline alone. It needs to be multifaceted. We need to look at it from a systems level. So at the national level, what can we do to advocate, to legislate, to ensure that practice is available to all services, regardless of location? Then at a meso level, what about within services and within communities? What can we change? And then finally, at a micro level, what about for paramedics and other clinicians, and also then for patients, families and carers? What interventions should be aimed and targeted at these individual systems and services to ensure that we can evoke sustainable change going ahead? The final participant quote, this is from a GP. We need a policy that ensures it's a requirement for paramedics to have some hands-on experience in a palliative setting, an aged care setting, for example, demanding that there are placements in aged care homes. This was just one intervention that was recommended. So our final study that we're currently conducting, and I note some of you online today are participating. Thank you so much for your ongoing expertise. It's been a delight to read your responses. What we're doing is developing a palliative paramedicine framework which will be suitable for national implementation through a Delphi consensus method. The first part is to gain consensus regarding the framework components that we consider most essential for improving palliative paramedicine in Australian communities. And then second, to understand the barriers and elicit recommended strategies to underscore the future implementation of this framework. So that will be in focus groups down the track. We've included a range of international and Australian stakeholders with expertise in palliative paramedicine, those coming from the palliative care, paramedicine, general practice, educator, policy and research, and consumer sectors. I'm delighted to report a very, very preliminary and secret summary of our first round of the Delphi. And as I said, we are breaking down the components of the framework into macro, meso, and micro levels. In the macro level, we're focusing on the highest levels of the aggregate healthcare system for organising specific responses to palliative paramedicine at that structural or national level. And the confirmed components that we have so far, I've just listed a couple, but of particular interest to this webinar is the third one highlighted in red there. We had over 96% of our participants agree, and strongly agree that we ought to embed paramedics curriculum into palliative care curriculum into paramedicine undergraduate and postgraduate, including theoretical and practical components. So we want to see palliative care being a fundamental and compulsory component of paramedicine degrees going ahead. We also have confirmed on the meso level that we want to see healthcare services recognise the scope of practice of palliative and end-of-life care, provide specialist training pathways for paramedics interested and with that capacity to broaden their scope. So we recognise that not all paramedics will want this to be their number one, but there will be those that show interest and capacity, and we want to give them opportunity to be able to shine. And also develop public health palliative care campaigns to educate health professionals in the community on the role that paramedics can provide in that type of care. As we spoke earlier on about that expectation of what a paramedic is in community, unless we challenge that in society, we are going to experience a lot of kickback from community around what the expectations are of a paramedic. And finally, from a micro level, the confirmed components was mandating generalist capabilities of palliative care for all paramedics, providing paramedics with access to self-care and peer support services, including the debriefing opportunities, particularly for expected and unexpected death. And also educating families and carers to provide paramedics with contact details of their loved ones' healthcare services, including GPs and palliative care services, so that if a paramedic isn't able to perhaps contact the ambulance services clinical backup, they may be able to get that clarification and confirmation from the patient services. So that's just a very quick snapshot. The Delphi study is going to be due for completion, data collections finishing up in May, and we'll be getting that a manuscript out and hopefully published later this year. So thank you so much for listening to me bang on about the brilliance of palliative paramedicine.
Thank you so much, Madeleine. I'm sure we could listen to you for hours more. Yeah, really, thank you so much for that. It's very engaging, and just the work that you're doing is amazing, and we can't wait to see how it all finishes up. So we do have time now, and I'm grateful that we've got a reasonable amount of time. Sometimes we rush through and then have only a short time to talk, but really pleased to see so many different people here with us today online, and I'm really keen to hear from you. To get the ball rolling a little bit, I guess, we'd like to just hear firstly from Julie Johnson, who's joined us today representing the Australasian College of Paramedicine. And really, Julie, just interested in hearing about what your take on this is, and perhaps what the college's plans or future looks like for palliative care education. Are you there, Julie? I did see you earlier.
Yeah, thanks so much. Thanks for the opportunity, and it's really great to hear you, Madeleine, speak so positively about the growth and potential for paramedics to be engaged with palliative care. And I think it's hugely important. And yes, I agree, we might need to be, looking at embedding it into undergraduate and postgraduate curriculum. But when we consider the amount of qualified paramedics we have with experience working already in the industry, and not just limited to jurisdictional ambulance services, but how can paramedics engage in community health and support people to die as they choose to, whether that be at home or in another setting. I think we also need to look at professional education and professional learning. And I think that's where I'd like to engage with you all and see how the college can assist. And I've written, I can't tell you how many pages of notes already on, how we can simply assist to start that conversation with paramedics working already. And I think it's a two-headed sword, is that we have students that we can look at improving curriculum design and development and embedding it. And I think we have already existing qualified paramedics that we can engage with professional learning in. And that's something I hope that the college can assist with. And I'd be really keen to chat with you offline, Madeleine, and support your PhD further.
Thanks so much, Julie. I would be delighted to speak with you as well. And I think you raised such an important point there. Sorry, Sharon, do you mind if I jump in and respond to Julie? Is that okay? Is she there?
You got a thumbs up. That's
Sorry,
great, Madeleine.
I didn't want to interrupt. Just go ahead. Absolutely. That's what we're doing.
Julie, I think you make such an important point there, that it doesn't just start with graduate paramedics, but it's also really important to ensure the sustainability of education and training throughout the entire workforce. And those existing in the workforce already certainly need to have that access as well. And one of our components in the framework is these mandated and standardized training across the board, not just for graduates. We appreciate that those with experience already in paramedicine are likely to have exposure to palliative and end-of-life care. And we know that a lot of those integral skills around communication and eliciting goals of care are something that come with practice and experience from older paramedics, but they too are deserving of that training and education.
Look, 100%. And I think it's fantastic to see everybody on the same page. And I think it's just a matter of finding the right platform to bring the information together sometimes. It's the same, I think everybody's overburdened and fatigued within the industry, health in general, not just paramedicine, but health in general. People are very overburdened and fatigued. And especially in light of, I suppose, what's going on in the world at the moment. It's not just significant to paramedicine, it is across the board, that how we make, or how we, I suppose for me, it's accessibility and availability, so that people can engage in learning and it's easy, and we don't put up those barriers that makes engagement challenging, is that we really facilitate an ease of engagement, so that we are, and I think, you know, paramedics that I speak to, and I am also a paramedic as well, but I'm no longer like you, Madeleine, working on the front line, but I still have strong connections to the industry, and the paramedics, you know, overwhelmingly that I speak to want to know more. They want to be able to do more, but it's a challenge to find the right information at times. So I think this goes a long way to bridging that gap.
Yeah, thank you, Julie. You've just provided a wonderful segue into the next person that I tapped on the shoulder to share some information today. We're joined by Olivia Hedges, who's at Ambulance Victoria, and they've actually been working with our Pepper Victoria team and implementing some education for their workforce. So love to hear from you, Olivia.
Gosh, what great speakers today, and what a great chat for us all to have. The first thing I might say just before I go into what we're doing here at Ambulance Victoria is I'm not a paramedic myself. I come from a nursing background, but I'm very fortunate to work with a wonderful group of paramedics to help inform our project work and where we go in the space. I've come into Ambulance Victoria this year to look at a project that's basically uplifting us, well, with the hope to uplift us to sort of best palliative care. And listening to Madeleine speak, it's almost like a song sheet for exactly where we're at with Ambulance Victoria in terms of risks, our barriers, and our current state, and just the trickiness of both. There's pretty much everything in there I would actually say was relevant, but silos is a big theme, training, education, and a knowledge gap is a big theme, and exposure gap is another big theme. And for us, we have quite a junior workforce, and by that I mean around 80% of our paramedics have less than 5 years training. The other issue that I think Madeleine spoke to, and I can hear coming through in other elements, is that tricky state where we're in as an emergency service provider, but also moving into sort of shared care models, or the fact that a lot of our call outs now are actually for older people with complex comorbidities, or for palliative care or mental health, that's actually a core part of our work. And how do we meet the needs of both? I came into this project when the initiation and discovery phases had been done, and what that clearly showed was that paramedics were really thirsty for some palliative care education, that there was that exposure, knowledge and training gap. People were actually uncertain of when they were doing a good work in the space, or not necessarily the best practice in the space, because we didn't have the processes embedded in our practice for review. We looked at developing an education package, and we were very, very fortunate, and a big shout out here to Molly and the team from Pepper and Sharon, that all of the key criteria that we wanted to be embedded in our education package was already done by Pepper, and it was brilliant and tailored to that paramedic scenario. Our continuing education team has been working in partnership with Pepper to further develop these modules just to meet our Ambulance Victoria specific context and make sure it meets our state legislation. And we're hoping that we'll be able to go live with this, approval processes pending, sort of in the coming weeks. For us, there are constraints in mandatory education time in particular, and I imagine that's probably universal across the board, and that's something that could be really difficult to work around. We've been very fortunate to have some extra education hours become available for this particular palliative care education package. But I know with ambulance services being this big, broad emergency service, and with paramedics having this very, a very huge and sometimes, generalist role across the lifespan, across all specialties, it can be difficult for us as palliative care advocates to get that time. But we're going to embed monitoring. We're going to embed monitoring into this project as well as feedback, so we can look and see how paramedics uptake this education package and how it changes their practice.
Wonderful. Thank you, Olivia. That's great to hear. We do want to have some time for your questions, so please feel free to unmute yourselves. This could be a riot, but I'm guessing not. I'm pretty sure you're all well behaved. unmute yourselves and ask us a question, or pop it into the chat if you'd rather do that. We did have a question just while you're thinking or getting yourself geared up. We did have a question while Madeleine was presenting from Sarah, which I think Madeleine might be able to respond to.
Sure, thanks Sharon, and thanks Sarah for your question or comment rather. And I think that this has certainly been echoed by other participants in the qualitative study, and then something that we put forward to the Delphi as well. A recognition that it's not only about training paramedics in other services and in other environments, it's also about other services and health disciplines understanding what paramedics do. And we're advocating for bi-directional training opportunities to ensure that there is an appreciation, a mutual appreciation and recognition of the roles of all healthcare disciplines, because I think that that is actually what is primarily important in reducing and pulling down those silos, understanding where you can lean on your healthcare partners and ensure that we are engaging in a multidisciplinary approach. We talk about multidisciplinary all the time, but I mean it sincerely, ensuring that paramedics are able to be able to call up for clinical backup support, but they're also not being called out unnecessarily to patients and to cases that are not suitable for their type of care. And I know that that is a great frustration for many paramedics. We've all had the circumstances where a paramedic is called out to a patient ready to go with their bag, waiting for a lift to hospital, and it can be very frustrating and annoying. But on the same token, being able to understand when it's an appropriate time for a paramedic to come out. So that would be my response to that.
Thanks, Madeleine. Any other questions, comments?
Hi, sorry, can you hear me?
Yes.
Beautiful. Just in regards, so I'm a recent graduate paramedic working in the non-emergency patient transport sector. In terms of research looking into it, was there any looking into ambulance attendants and patient transport officers? In the year and a half I've worked actually in that field, I have come across quite a lot of palliative care patients, and I echo all those words in my training over my 3 years that there was nothing in terms of palliative care or that approach. Was there any look into the patient transport sector as well?
I can answer from my perspective of the research that we've conducted. There was recognition that it's not just generalist paramedics that are coming across palliative care patients, but it's across the board. So certainly those engaging in patient transport, as well as more senior in intensive care, extended care, and even rescue paramedics are coming across these circumstances. So I would certainly be advocating for training and education to all. There's a real, when I first started this research, there was kind of a school of thought that maybe we should be delegating palliative care to specialist paramedics, similarly to the notion of having extended care paramedics doing that community kind of complex comorbidity care in the community. And what we've come to realize very quickly is that the demographics of our society is rapidly changing. It's no longer apparent that we'll be going to, motor vehicle accidents and cardiac arrests for all of our patients. That you are going to be going to an aging elderly population with increasing comorbidities and palliative and end-of-life care needs. So I absolutely agree with what your question and your sentiment, and would be advocating strongly for education and training to all, not just a specialist segment of the paramedic workforce.
Yeah, thanks, Madeleine. Carly and I had a conversation with a paramedicine unit coordinator here at QUT last week about similar issues, and just the opportunities, I guess, that paramedics have in all kinds of contexts to build in those palliative care skills, particularly in the areas of communication, talking about people's understanding of their illness and the trajectory that might be taking. And also just thinking about goals of care and asking some of those questions. For example, when there is a situation in transport and you've just got time to chat, perhaps there can be those conversations. And when paramedics develop those skills around having those kinds of conversations, then their confidence level will build as well.
I don't know if this would help other people, but just in case it would, I know there was the question about the GP, the comment that was made from them. One of the things that we've found through going through an engagement program with all of the external palliative care service providers, and in Victoria we're divided into palliative care consortia, is actually there were a lot of misconceptions about how the ambulance services operate as a whole, and then what level of training, exposure, experience, comfort, confidence paramedics would have in approaching palliative situations. And that has actually been really revealing. There's also, I'd say, a lack of awareness for us in terms of what palliative care supports are available actually to the paramedics to support them on road. So part of what we're doing at the moment is actually building those relationships together and making sure everybody is actually on the same page about how we'll all work together to provide best care to the patients. I don't know if that's common in other states. If anybody can have something that they'd like to speak to, that would be helpful too.
Thank you, that is helpful.
I just wanted to add in, I started typing it, but it'll take me too long. I see a real parallel here. My background's nursing too. Through how nursing's evolved with palliative care. Early in the piece, there was this real focus on everyone having to be a palliative care specialist. And we've evolved to the point where we've realized, no, everyone doesn't need to be a specialist, just like everybody doesn't need to be a renal specialist or a diabetes educator or whatever. However, everybody dies. Everyone doesn't get renal disease. Everybody doesn't get diabetes, for example. So every clinician, shouldn't matter what their discipline is, needs a basic understanding of the palliative approach to care and confidence in being able to provide that. And I'm talking about everybody here, including non-clinical staff, the cleaners, the maintenance staff, the people who work for catering. That we've got a lot of work to do in this space in empowering communities to actually own death and dying. And that includes people who don't work in health, who work beyond that, teachers, others. So I'm not, Madeleine, I don't want to throw all this at you, but I'm more than happy to help you in any way I can, because I've been doing work in this area for a long time, and it can be really challenging because there is lots of ownership around specialties that shouldn't be there. We should be all working together in order to get the best possible outcome for our community. So that was just what I wanted to say. And when you're ready, Sharon, I'll talk a little bit about Pepper, because I think a lot of the questions that have come up, Pepper already has systems in place to support that.
Yeah, I think no time like the present, Molly. There was another question in the chat about Pepper and placements, and Kylie's shared a link there to the Pepper website and just mentioned that we have Pepper contacts in every jurisdiction, so you can just go to the website and find your jurisdiction and make some inquiries. But I'll let Molly talk a little bit about the placements. So
Pepper is a two-pronged program that's Commonwealth funded. There's a Pepper program in every jurisdiction. Without going into the history of it too much, it's been around for 20 years. It's a system that works. I've been involved in it as a host site. I've been involved in it at a management level years ago, and now I'm back running the Victorian program. Pepper not only offers evidence-based education tailored to the needs of individual organisations, and we will come to you to deliver that. It's free, but we also offer placement opportunities. So in the last 2 weeks, we've organised something like 30 placements into specialist palliative care for people from a range of disciplines: GPs, nurses, allied health, lifestyle people, aged care, personal care attendants, disability workers, across the board. So anyone working in a health environment can apply for a Pepper placement. So I think there's a whole opportunity here if we can all work together to achieve some outstanding results, not just for the paramedic community, but for the the wider health community, and for our community at large. So that's my pepper sales pitch. Please contact me. I'm always happy to talk about pepper, always happy to help you out. That's it.
And that's 100% true, she is. Thank you. We are sadly running out of time, which is, I guess, not unusual for us, but I really want to thank you for your contributions to the conversation, and to those people who are answering some questions in the chat. I'm really grateful as well. We obviously aren't going to get through everything today on that. we're just going to run a quick poll for those of you who can stay for a couple more minutes, just to see how you found the webinar today. So Karen's going to get that up on your screens. There was just one question that I wanted to come back to from Rhiannon. And just your question was about if it's going to be rolled out across Australia and New Zealand, will it be funded or mandated by the Federal Health Department? I wasn't sure if you're talking about the education resources, or if you're talking about Madeleine's work and the guidelines. But if you're talking about education, I can help you. It is already available freely online, and you can access it from New Zealand as well as Australia, and it's funded by the Australian Government Department of Health. So all our resources are available at no cost. And one of the other things that we provide as part of our project is support for educators in implementing our resources. So we've got a lot of implementation information, but we also provide one-on-one sessions to help you work out which parts of our resources would be good for your students or staff to use, and help you implement that as well. So thank you for those of you who are completing our poll. Just want to, before we go, give you a quick plug for our next webinar session. And also, if you'd like to continue coming to our webinars, you can join our PCC4U educator community, which is available through our learning management system, palliativecareeducation.com.au. You can just sign up and join our community. That would be fantastic. Our next session is on the 16th of May, and we have we're shifting gears a little bit and heading up to the Torres Strait. And we're hearing from Miriam Kavanagh, who's a lecturer in Aboriginal Torres Strait Island Health, and looking at how we've got content, case study content that can help you support students to learn about this area, which we understand is very rare offering. So if you're interested in coming along, you can register here. If you join our community hub, you'll find the links in there as well. So that is all we have for you today. Really appreciate you joining with us, and thank you for all your questions and comments, and hopefully we'll see you again.